And my disclosures, I'm consultant for Augmentics, and I'm the editor-in-chief of Brachytherapy, the journal. So combination therapy, I think we've heard, is really, I would say, the most potent form of dose escalation that we have in our armamentarium to address locally advanced disease. There is no way to deliver these kind of dose levels with external beam radiation alone. And we've pushed it to 81 gray with some hot spots up to 90 gray, but it doesn't match what can be done successfully when we combine brachytherapy with external beam radiation. And for high-risk disease, combining these is really the most conformal way of delivering high-dose radiation. It allows us also to start considering, do we really need to treat the entirety of the gland, or could we get away with, at least for part of the boost, with focal dose intensification to a dominant lesion where generally these tumors would ultimately recur. And of course, we've heard this theme already in this session, that we need to deliver this kind of therapy with a great deal of caution by experienced practitioners and employ careful dose planning with tight constraints. We've heard this theme regarding sexual function, regarding urinary morbidity as well, and I think I'm just providing an additional perspective along the same lines of this session. And here's the concept where we've pushed with 3D CRT with IMRT to dose levels of 81 gray, and in a biopsy cohort of patients who underwent a biopsy 2 years to 3 years out from treatment, despite receiving these high dose levels, about 30% of patients had a positive biopsy. Despite the high doses of radiation, we still had local residual disease. We've heard in this session about this important randomized prospective trial from Canada, 398 patients. It's a randomized trial, and 2/3 of the patients had high-risk disease. They both arms had 12 months of hormonal therapy. And again, that breached some of the considerations of using for especially high-risk disease up to 18 or 24 months. And I think the concept also here was that if you're delivering these super lethal doses of radiation, do you really need all of that hormonal therapy in this group? It's an unanswered question in truth, but nevertheless, both arms received a somewhat abbreviated course for high-risk disease, and that is 12 months. And we've seen this slide already, a substantial improvement in PSA relapse-free survival at this time, about 25% different. And these data I was expecting should have changed practice throughout the country, maybe throughout the world. We didn't see yet overall survival benefits, but with this kind of a difference, I would anticipate in another number of years, we would start seeing, especially from the high-risk patients, differences in distant metastases-free survival. But this is what has gotten in the way. And I remember when these data were presented at the ASTRO meeting, the non-brachytherapy users were definitely highlighting some of the toxicity that was observed, the GU morbidity and the GI morbidities as well. And I think Dr. McLaughlin pointed these out, that the difference here are not that dramatic. However, again, if you just look at the grade 3 rectal toxicities with combination versus external beam alone, this is grade 3, 8% versus 3.2% in a randomized trial. And this basically generated among the non-brachytherapy users the contention out there that combination therapy is too toxic, despite the fact that there are many institutions, including the broad experience from Dr. Stone and Stock, the broad experience from other institutions as well, that this does not have as much morbidity as what was reported here. Well, what did they report? Urinary toxicities for this combination. In 16% of those that had this combination, there was a late grade 3 GU event. 16 requiring dilatation, 4 required TURP, 5 developed severe urinary incontinence, while lower for the dose-escalated SBRT patients, similar kind in terms of urinary toxicities, but more often observed in the combination therapy group. Late catheterization was also reported as a concern for those who received the combination therapy, with the combinations showing late need for catheterization 12% versus 3% for just beam alone, and so on and so forth. And so, what's the reason? Why did the combination therapy reported in a randomized trial have an associated high levels of toxicity, and I would say much higher than what had been reported previously in the literature? And of course, when we see data from a randomized trial, we will take that with a great deal of serious attention. Most of the GU toxicity, however, was the development of urethral strictures. And strictures are well known to be attributed to the overestimating of the inferior extent of the prostatic apex. Dr. McLaughlin has showed that a lot in his data and how MRI is so critical in identifying the apex, resulting in the treatment more of the GU diaphragm. And that kind of I'd say over coverage, especially in the GU diaphragm, is not commonly practiced in the current era of treatment planning, and with experienced brachytherapists, we don't see as much, I would say, this kind of overdosing or coverage of the inferior part or the apex and below. Many complications also resolved. The prevalence of grade 3 GU toxicity in this randomized trial was much diminished, and as you went on with longer follow-up, less than 10% of that kind of grade 3 toxicity if you look at the data in either arm. And this prevalence rate is still markedly less even than what it has been reported than the grade 3 incontinence rates, impotence rates, stricture rates after radical prostatectomy and other phase 3 studies. So I guess my point is that with the reported toxicity outcomes, many practitioners have been reluctant to use combination therapy despite superior tumor control compared to SBRT alone. And I think that is shameful and unfortunate that perhaps because maybe of the, I guess, lack of comfort of using combination therapy, we throw that out and not take advantage of how we could address morbidity, reduce morbidity, using more careful planning techniques, in addition, of course, to the experience. But there are opportunities for the general practitioners to reduce that morbidity. Instead of taking advantage of CMRT as the most potent local therapeutic intervention, some would prefer still to really only use SBRT and ADT as the standard regimen. And yes, it's been shown in randomized trials to be used in high-risk prostate cancer, but now we have at least randomized trial demonstrating its superiority. Morbidity is in the way, so instead of just throwing that out, let's address morbidity. How could we reduce more effectively the morbidity, the urinary morbidity associated with combined treatment, if not to adhere to very specific and carefully done techniques? And with careful selection, which is also, of course, very important as well. Not everybody is a candidate for combined modality therapy. If they have severe IPS scores, very high, of course you could get away with it, but there are patients who are not optimal candidates for it. If they've been previously treated with other forms of therapy, like failed cry or a HIFU, they may be a little bit more concerning for long-term toxicities as well. So we've used, even in terms of combination therapy, and we don't have a lot of data in terms of long-term follow-up on it, but I'd share with you a phase 2 study that we recently completed about a year or two ago. The PI is Marissa Kohlmeyer from our institution. I think trained by Drs. Stone and Dr. Stock initially for brachytherapy when she was at Sinai. And the palladium 103 initially prescribed to 100 gray, followed by SBRT 25 gray in 5 fractions, given every other day. Now we give it even every day. The SBRT targets, instead of giving 5 weeks of external beam radiation, we give 1 week, basically, or 1.5 weeks, targeting the SVs with 5 millimeter circumferential margin, except at the prostate rectal interface where a 3 millimeter margin was used. Once again, this was for intermediate risk disease. And most received a rectal spacer, SBRT, with MRI-only treatment planning, which we are fortunate to use at our institution. I'll talk briefly about it. And the prostate moves during external beam radiation. Well, the beauty of brachytherapy is that the seeds, in particular, are moving with the prostate, so organ motion is not as concerning as the external beam component. And therefore, it's imperative to target accurately, not only for accuracy of targeting of the tumor, but also of the normal tissue as well. And so combined modality regimens with the reported toxicity outcomes, people have been reluctant to use brachytherapy despite the superior tumor control. And here is an example of our MRI simulation and planning. We plan actually everything off an MR and not any longer off a CT scan. I think, as Dr. McLaughlin has explained, the importance of MR visualization, our target volumes are certainly smaller now than the overestimation we routinely utilize with CT scanning. We could see where the clinical target volume is, where the urethra is. Here's an example of a rectal spacer providing added space between the prostate and the rectum, and see on the various reconstructions from the coronal and sagittal images as well. In Dr. Kohlmeier's phase 2 study, again, of SBRT plus palladium implant, we saw dramatic reductions in the PSA, and these are all patients without hormonal therapy given, and so you could see these dramatic reductions, mere reflections of the potent dose escalation that was used with this combination therapy. And here are some of the toxicity outcomes as well. And again, in terms of late GI toxicities, I mean, we're not seeing really much, despite the dose escalation therapy that had been delivered to these patients. And again, for grade 3 late GU toxicities, 1 in this group of 40 patients. Well, what is this related to? And I think any radiation oncologist would recognize how important our physics colleagues are to help us plan radiation therapy, not only for the brachytherapy, but of course for the external beam components as well, adhering to tight dose constraints for the rectum, for the bladder wall. We also utilize constraints for the urethra, for the bladder neck, and for the penile bulb as a surrogate, also in the neurovascular bundle structures as well. And so SBRT is one of many things we are doing to try to further reduce morbidity for what is clearly one of the most potent forms of dose intensification that we could use for our high-risk patients. As I just mentioned, the phase 2 study that we certainly need longer follow-up, but the notion of trying to target the radiation in a more accurate way and also reduce the burden of that prolonged therapy on the patient as well. Seed implant or HDR in combination with a 1 week of treatment is a very attractive form of therapy for the patient. And then in high risk specifically, currently we're using a lot of, for high risk, HDR as a single fraction, plus SBRT to the prostate and pelvic lymph nodes, 5 gray times 5, and we're currently doing that in a prospective way. And then we have Dr. Sean McBride is the PI of a multi-center trial emanating from our institution called the ASSURE trial, which leads into Dr. Crawford's talk, where we're using testosterone annihilation in this group of patients, abiraterone and apalutamide and leuprolide, but here taking the concept of if we could use intense forms of radiation, perhaps, and again, it should only be done in study form, prospective studies, can we get away with just 6 months of hormonal therapy with intensification of the hormones and intensification perhaps of the dose? And so this is a study of using this form of, one form of testosterone annihilation with SBRT, interestingly, just to the prostate and not to the lymph nodes. That was the decision of this multi-center group. And this is just finished accruing patients, so we need longer follow-up on that. But then we can start thinking about maybe in the next 5 or 10 years, with some of the advantages of molecular imaging that have come along, do we really need to boost, with brachytherapy, for instance, the entirety of the prostate? If we have, with good imaging, the localization of the dominant intraprostatic lesion, where most of these tumors recur, can we actually get away with intensification, focal intensification, in the future without treating the entire gland and further potentially reduce the morbidity of therapy? Boosting the DIL while treating the remainder of the gland still, of course, but intensifying the dose there could improve the therapeutic window. And there are technical challenges, obviously, with the kind of fusion that's necessary in the OR, the accuracy of delineation, the image fusion, and some of the treatment paradigms for prostate cancer. And I think that these things obviously need to be worked out in the future, but this may be a very important concept which is currently being tested. First of all, the notion that the DIL is the most common site of recurrence has been out there. Data even from our institution, from salvage prostatectomy specimens, demonstrate that the dominant nodule harbors the most aggressive disease in 80% of cases. 90% of cases, these are the sites of failure, ultimately after treatment, after radiation, and they're most likely to occur at the site of highest burden of disease. This is where we should be intensifying our doses to, and potentially we could further reduce the morbidity of combined modality therapies. And we have the tools now that are emerging, even PSMA, the Regimens scans, multiparametric MRIs, and the improving radiation techniques are now putting us in a very attractive position to be able to achieve dose intensification, and I would say focal dose intensification. And here's one of a number of trials where HDR dose intensification to the DIL is being used to 18.75 gray. This is the group of Juanita Crook's group. And again, a combination of a single dose of 15 gray with that dose intensification to 18 gray. And we're routinely doing this now as well. In patients, again, with high-risk disease who have an identifiable dominant intraprostatic lesion. And there are a number of studies, again, this is just to point out, the ones that have been completed, the green ones that are ongoing, that are really taking advantage of focal dose intensification in combination with some forms of radiation or brachytherapy. So here are my conclusions. SBRT appears to be safe when combined with brachytherapy based on our phase 2 intermediate risk study that we've completed. We still need longer follow-up, but at least it's encouraging that when we use tight margins, and again, with a similar BED ultimately to 45 gray of conventional external beam radiation, we're really accomplishing the same in a shorter duration of time. The preliminary findings suggest excellent 2-year PSA relapse-free survival with low toxicity rates, and we still need to monitor that in a longer way. The post-treatment biopsy outcomes in that particular study happen to be about 5% only. And the advantage of such an approach is to reduce the burden of therapy on patients. And ultimately, I think there are going to be more and more studies in the future as we get a comfort level on where the burden of disease is from improved molecular imaging, functional imaging, that is now becoming available, high-risk disease with more targeted boost, taking the advantage of conformality of brachytherapy, may further limit toxicity in these patients. And I think we need to be cognizant of what has been really eloquently mentioned throughout this session already. We have an incredible tool, and that's combined modality therapy. We have observed that if there's not that much attention given to technique, that may be associated with morbidity. The challenge in the oncology community is to address that morbidity by making it consistent in terms of adhering to dose constraints, adhering to what the normal tissues get, and be as tight as we can, and ultimately the morbidity will be less, and we will be using the best form of therapy for our high-risk disease. Thank you for your attention.